Hello and welcome to North Shore Private's virtual GP education program. This session was recorded at a live GP education session in April 2023. The topic, Liver and Gallbladder Disease Updates, covers gallbladder polyps, MAFLD and liver cancer. Speakers on the night were Professor Tom Hugh, General Surgeon and Hepatobiliary Specialist, Dr. Nirmal Sadanyaki, Gastroenterologist, and Dr. Kai Brown, General Surgeon, Hepatobiliary and Pancreatic Specialist. Use QuickLog to gain CPD hours for this session.
So Tom Hugh is my name. I'm an upper GI surgeon at Royal North Shore Hospital. I think there are some familiar faces here that I've met before. I've been walking these grounds since 1983. I feel like I'm part of the furniture. Obviously, the building, the infrastructure was changed, but I was fortunate and privileged enough to be a medical student through Royal North Shore Hospital. And as I said, I first came here in 1983, which to these whippersnapper doctors here seems like a long time ago, but it only seems like yesterday. And it feels very much like home. Things have obviously changed in terms of our campus, but it's essentially the same hospital, and I feel very proud and privileged to be part of that. So I'm an upper GI surgeon. I trained in general surgery and then focused on upper GI surgery. And then, like many specialists, I super focused, and my areas of interest are essentially hepatobiliary surgery and hernia surgery. Very focused. I know that can be irritating for GP referrals to understand and know that, but that's the facts of what I do. So tonight I'll be talking very briefly on gallbladder polyps. It's a common problem, and I'll try and keep it as straightforward and simple as possible. It's relatively simple. And the key point is that we don't know all the answers about gallbladder polyps. I think that's the message I wish someone had told me 30 years ago, that there are a few uncertainties, but we have a few key messages, and I'll try and give these key messages tonight. So the first thing to say, as most of you know, gallbladder polyps are common. Ultrasound is a very readily accessible and widely available modality of imaging, and so we see polyps a lot, and arguably we're seeing much more than we used to see 20 or 30 or even 40 years ago because of the ultrasound usage. And they occur relatively frequently, as shown here in the population, and they sometimes do pose some difficult problems just because the gallbladder polyps are there and not necessarily the cause of the patient's symptoms, or not necessarily anything that you need to worry about. The key point is that most gallbladder polyps are completely benign, and then what's known as cholesterol polyps. They're made essentially mostly of cholesterol. They've got nothing directly related to the serum cholesterol, and many of them are in fact inflammatory polyps. They are unlike the polyps that we traditionally think about, which are in the bowel, which we know have a very well documented, well understood polyp to carcinoma sequence. They're quite different from those. Very few growths, I'll call them growths, polyps in the gallbladder are in fact neoplastic. It's a rare cancer, gallbladder cancer, one of the few very rare hepatobiliary type cancers, less common than even cholangiocarcinoma. The issue really about polyps, which I want to focus on, relates to their risk of malignancy and whether you should worry about them. So there are two separate issues. One is about whether they may or may not be causing symptoms, and the other thing is whether there's any risk of malignant change. It's quite difficult from ultrasound imaging, and I'll repeat that from what I said before. It's the best modality for examining the gallbladder, far better than CT scan or MR scan. A little bit of argument about the MR scan, but certainly much better than, we lost the mic, yep.
Got battery, sorry everyone.
Far better than CT scan ultrasound imaging. And it's very difficult sometimes to differentiate between whether it's a nasty gallbladder polyp, malignant, the rare type, or something that you don't need to worry about. The point, again, about cancers in the gallbladder, very rare. Most of them arise in some sort of flat sessile polyp rather than a raised polyp, which is the majority of gallbladder polyps. So they're raised in an area of abnormal epithelium rather than in a polyp in a traditional bowel sense of a polyp, benign polyp turning into a carcinoma. So they're just some important points to remember as I go through this talk. This was an excellent study out of, in fact, conducted by Sarah Wemmarker, who was a Dutch fellow that came through our unit a couple of years ago. And she conducted, looked at a Dutch study looking at a large database and used a data linkage method to look at the types of benign polyps that exist. And you can see from this graph here that the bulk of them are these so-called cholesterol polyps. And then there's this other entity called adenomyomatosis, and you'll sometimes see that in an ultrasound report. And that does also cause some confusion. Essentially, that's again a benign pathology. It's really a hyperplasia, thanks Kai, a hyperplasia of the epithelium or the muscularis propria, and it has some characteristic histological features, Rokitansky-Ashkoff sinuses they're known as. That's not what's important. The issue is, can you differentiate it from something malignant, and does it cause symptoms? And that's a bit controversial. I'm happy to talk about that later today. But those two entities, cholesterol polyps and adenomyomatosis, make up the bulk of these benign polyps. And then there's a scattering of other things like inflammatory polyps and the rare hematomas and various other things. The gallbladder polyp shape and the number are the two most important issues to look at. Most polyps, as I said, are small, less than 5 millimetres, usually in the order of 2 to 3 millimetres. Most of them are symmetrical and round in shape, and I'm going to touch on a few issues about shape in a second. They're called polyps by the radiographer because when they roll the patient, they don't move. It doesn't mean that they're not a small gallstone, and sometimes we do find that when it's advertised as a polyp, it turns out to be a gallstone. They call it a polyp because it sticks to the wall when they move the patients during the ultrasound report. Most of them are single, but they can be multiple. The golden rule about gallbladder polyps, many of you might know this, if they're larger than 10 millimetres, it's not that they're going to turn into a polyp. It's much less likely that they are the bog standard cholesterol benign types of polyps. That's all it means. So if we see a polyp that is more than 10 millimetres in maximum diameter, we have to seriously think about whether that should come out, because that could be one of these rare gallbladder cancers. It also could just be a large gallbladder polyp, although they're less common. The problem is that if you're older, it's more difficult, and that is the cutoff is usually about 50 years of age. It's more difficult to interpret size, and I'll come on to that in a second. And people argue about whether the absolute size criteria of 10 millimetres is too strict. The problem is, if you have a polyp that's small, that's easy. It's a benign cholesterol polyp. It doesn't have any nasty features. Treat it. Either treat it for the symptoms, and we'll talk about that in a second, or don't take their gallbladder at all. The problem is for those polyps that are less than 10 millimetres but more than 5 millimetres, the 6 to 9 millimetres, and that's where it gets a bit tricky. We'll talk about that again in a second. It's the shape that's the most important, and radiologists know about this, and they try and talk about this. And as I indicated before, it's the flat polyps, the sessile polyps, that are more concerning, particularly if there's an associated focal gallbladder wall thickening. We don't mind all of the gallbladder wall being thickened. That indicates inflammation, usually, but when it's focally thickened, we're concerned about a neoplastic process. And then there are the risk factors. So if you have a polyp and then you have these other risk factors, that's when we might push towards taking out the gallbladder as the only solution to ensure that it isn't malignant. And these include older age, as suggested, over 50 years of age, a history of an inflammatory disease within the biliary tract or in the colon, inflammatory bowel disease like ulcerative colitis, Crohn's disease, or sclerosing cholangitis within the liver, and certain ethnic groups as well, and I'll touch on them in the next slide a bit more. This is the same slide, but just a bit expanding. There are well-known ethnic groups, which presumably genetic. It's difficult to tease out whether it might be environmental like dietary, but they have much higher incident rates of gallbladder polyps and therefore gallbladder cancer. And the two go hand in hand, and probably go hand in hand with the incidence of gallstones as well. I won't go into more details because it's a bit complicated. Just showing you now a few pictures, and why do we think it's a polyp? It's pretty easy. If you look at your right-hand picture, there is a 6 millimetre abnormality. It's fairly spherical, looks pretty benign to my eyes, but it has a posterior echogenic shadow, and that's a classic finding of a stone. And if you look at the slide on the left, it's a little poor, a little hard to see, but it's the same size abnormality. It has no shadow. It sticks to the wall when the patient moves. They call this a gallbladder polyp. If you look at this, this is a 47-year-old male, wasn't eating too well, had a little bit of low-grade nausea. Obviously, everyone starts to think when they lose weight that this is a malignant process. And this patient has multiple polyps on in his gallbladder. It has been serially observed, but they're slightly increased in size. Everyone concerned this is a malignancy. In fact, we took the gallbladder out, and it's straightforward cholesterol polyps. This is what a cholesterol polyps looks like. And in fact, the patient probably had microcalculi to account for biliary colic, and that's why we're off the food. He got miraculously better after this operation, and there was no malignancy. It can get confusing. If you look at the left-hand picture here, May 2013, there was a slightly asymmetrical thickening of the gallbladder wall. If I saw that now, I'd be very worried about it. For certain reasons, that was observed only. And here is an MRI of the same patient 3 years later showing an enlarging mass, and that turned out to be a gallbladder cancer. So it's the type of flat sessile polyps like that that we get most worried about. Look at this huge polyp, 22 millimetres, a large polyp, but the thing that gives it away and makes it more likely to be benign is the large posterior echogenic shadowing. And rather unflatteringly, this was called a sludgeoma, or a sludge ball by the pathologist. It's a clumped bit of bile and gallstones, completely benign. Quite different from this 25 millimetre polyp, which is large, and you may be able to appreciate that here it is here. It's got a wide base. We don't like seeing a wide base that's infiltrating into the mucosa. This turned out to be a T2, T3, I can't tell, gallbladder carcinoma. So we get concerned about those. There's some very unusual shapes, and these are all patients that I've looked after over the years. Some of them may have been yours. Large 20 millimetre, what looked like a gallbladder cancer, but turned out to be one of these adenomyomas, again, a benign pathology. Another looks like a Christmas tree in the gallbladder. Didn't know what it was, but this is too large to sit on and observe, so we just simply do a laparoscopic cholecystectomy. And in fact, it turns out to be a large adenomyoma looking like a large polyp or a gallbladder cancer. So sometimes you can't tell. Again, another example. I can't tell exactly what this is. I think it's, don't know. I think in the gallbladder area, but it turned out to be mural hypertrophy of the gallbladder wall. A little embarrassing to explain to your patient that the gallbladder was essentially normal, but it's hard to ignore the ultrasound findings, and sometimes we have to act on that. Again, relatively large, what looks like a 13 millimetre polyp, because it's over the size criteria of 10 millimetres. We do a laparoscopic cholecystectomy, but in fact, it turns out to be absolutely nothing. Focal, mild thickening of the gallbladder wall. Again, you have to explain that. I'll still do that, and I'll be interested to hear Kai and Neem's thoughts on that, simply on size criteria. But this is where some radiologists are questioning whether we need to look more closely at what these lesions truly are like. Just an interesting example, we were doing a liver resection actually for cancer, and we saw this unusual, unexpected finding in the gallbladder on your left there, and when we took it out, it actually turned out to be adenomyomatosis, again, what was termed as pseudo-cancer by the histopathologists. But this is really where it gets very complicated, and Kai and I were chatting beforehand, and I think in reality, the majority of suburban radiology practices will not go into this detail, but some of the issues are, do we need to understand the shape of these things better? And so here is the Society of Radiologists and Ultrasound. They got together, mainly from Southeast Asia, where there's a higher incidence of gallbladder carcinoma, and put out these guidelines, consensus guidelines about what might be a low risk, a medium risk, and a high risk polyp, and for those, and a suggestion that if it's a high risk, they should undergo cholecystectomy to exclude gallbladder carcinoma. And essentially, it comes down to the shape. And if you look at all those, and I'm not going to go through them, but essentially, if it's a round shape with a thin stalk, it's likely to be a completely benign condition. If it's a round shape or an unusual flat shape with a thick base particularly, it's more likely to be a carcinoma, and we get concerned. And the laparoscopic cholecystectomy is just a fairly radical investigation. That's the way we like to look at it. And it gets rid of the problem. It's a relatively low-risk procedure, and it solves the need for ongoing surveillance. Here's the problem. Sometimes you get distracted by the obvious. So there's a polyp. It looks, I think it's about 6 or 8 millimetres. It's a good shape, straightforward. It doesn't have a wide base, so we're not concerned about that. But the real money is there. That's the problem. That's turned out to be a T2 gallbladder carcinoma, which was missed by the original radiologist. A second radiologist picked it up, and it's very easy to miss that. And that's cured by a simple laparoscopic cholecystectomy. So is the size criteria good enough? Again, as I indicated, we're questioning that. Traditionally was if it's more than 10 millimetres, more than a centimetre in maximum diameter, the gallbladder needs to come out, especially if they're young or have associated risk factors. But people are saying maybe we should increase that. Maybe we should be a bit more specific about the ultrasound findings and the unusual shape. And I've talked about that before. 30% of gallbladder cancers are less than one centimetre, and that's what's driving this international move by radiologists to say we need to be a bit more strict with our criteria and don't just sit on them. And really, the message I want to give is look for the high risk factors, older age, certain ethnic groups, and have they got an inflammatory bowel or an inflammatory biliary disease? They're the concerns. Now, I'm coming to the last couple of slides. What about some guidelines? I'm going to show you some complicated guidelines, and then I'll show you some slightly easier guidelines, which are more simple to follow. I am a surgeon, by the way, so we like simple guidelines. These were put together by a number of societies, and they're very detailed. And essentially, it says, if you've got symptoms from your gallbladder, and that requires a careful history, it doesn't really matter what the size or quality of the or shape of the polyps are. The patients need their gallbladder taken out. Now that assumes that there's a cause for their biliary symptoms. And again, it's worth having a discussion later on if you want to. Can gallbladder polyps on their own cause symptoms? Now, I would say they can't. I would say that if a patient's got symptoms and they've got gallbladder polyps, it's likely probably due to microcalculi, small stones we can't see, or due to a functional gallbladder disorder. And I gave a talk about a group like this a couple of years ago about what a functional gallbladder disorder is. But the polyps themselves, the consensus usually is that they're unlikely to cause symptoms. And so just because they're there, unless they meet certain resection criteria, you don't necessarily need to operate, and they're unlikely to cause those symptoms. If the patients have got no symptoms and they've had a polyp discovered, that's when it gets a bit trickier. As I said, pretty easy, over 10 millimetres, just take the gallbladder out, laparoscopic cholecystectomy, low risk, easy procedure. Not great evidence, but it's a strong recommendation. Easy if they're less than 6 millimetres. If they've got risk factors, you worry a bit more and you need to follow them up. And the conversation I have with the patients is, you're 45 years of age, how long are you planning to live for? They all have a good laugh at that, but it's usually 40 years, 50 years. Now that's, how long do you do the ultrasound for? Do you do it 1 year? Do you do it 2 years? I tell them, let's do it for a couple of years and watch how bored you get. More importantly, they get worried. Every time they go for their ultrasound, they think it's going to turn into a cancer, and it becomes a pragmatic conversation. And as surgeons, we need to be very careful not to be pushing over operating. But in the end, a laparoscopic cholecystectomy is a low-risk, easy procedure which takes the worry. And I often put it back onto the patient, and we have this co-decision about it. If they've got risk factors and they're low, you might increase the screening frequency. The problem, as I said before, was the 6 to 9 millimetre gallbladder, and that gets a bit trickier. And if it's 8 or 9 millimetres, who's going to quibble over a millimetre or two? The key point there is every year they go to a different ultrasonographer, and it depends on the angle the ultrasonographer holds the probe, and they might show a 1 millimetre increase and they all freak. So I say to them, look, it's 9 millimetres. Let's be practical. You either continue doing this and contain your anxiety, or we just take your gallbladder out. And often that's what happens. During surveillance, here's another important point I think is worth for you guys. If you've got someone on a surveillance program, when do you act? When do you re-refer back for consideration of cholecystectomy? Well, again, these are guidelines that are consensus only, not hard evidence. Obviously, if it gets 10 millimetres or larger, you need to consider, you need to get their gallbladder out. If it disappears, and they occasionally do, the patients always ask, but is it going to disappear? My own feeling is the reason the gallbladder polyp's there is because the gallbladder is dysfunctional. The gallbladder polyp shouldn't be there. It's a little bit more complicated than that. It's due to bile absorption, bile formation, etc. But there's an abnormality that's causing it there. So probably it's still going to be there. But certainly if there's an increase in the number or the size, and when you first see a patient, they've got 2 or 3, and then you scan them in 12 months and they've got 10, if that was my relative, I wouldn't let them keep that gallbladder. That's not a happy gallbladder. That's not necessarily based on a lot of evidence, though. We wrote an article a couple of years ago, and I've put them all on your tables. I think it's a fairly pruned down version of what I've just talked about. And within that article, I tried to do a simplified algorithm. And I'll just take you through that because it's really a simplified version of what I just said, which essentially is greater than 10 millimetres, as long as they're not high risk for a general anaesthetic, we take their gallbladder out. That's pretty easy. If it's less than 10 millimetres, the issue is, does it have any malignant features, the polyp? Are there any risk factors? So if there are no malignant features on the polyp, the radiologist said this looks completely benign, then the issue comes down to, is it small, less than 5 millimetres, or is it between the 5 and 9? If it's between the 5 and 9, are there risk factors? If there are, you might consider saying, look, have your gallbladder taken out to save surveillance. If it's smaller than 5 millimetres, recommendation was a pragmatic option. Do an ultrasound at 12 months and it hasn't changed and they're young, maybe consider doing an ultrasound in 10 or 15 years when you get to your 50s and 60s again. These are pragmatic recommendations, not necessarily based on hard evidence. In conclusion, most polyps are small, less than 5 millimetres. They're cholesterol polyps and they're usually picked up incidentally. Most polyps do not cause symptoms. And most of them don't require cholecystectomy. Occasionally they do because you're worried about risk factors, or occasionally because they're associated with symptoms due to other causes. Patients may become associated, as I said, because of gallstones or a functional gallbladder disorder. And here's the criteria for cholecystectomy as I outlined before. Thank you very much. I'm happy to take any questions on that at any time. So will we take questions now or at the end?
I can take questions now, but there's none.
Okay.
Young patient with polyps within latency.
In a young patient with polyps?
Can you wait and see?
Well, I think again, it depends on the size of the polyps, what they look like radiologically. If you do have a patient and it's a bit of a surprise, the first question is, why is the ultrasound being done? Is it being done because they have symptoms? If they have symptoms, pursue that. Biliary symptoms, in my experience, are much more common than, I mean, Nins, you might comment on this later, but much more common, certainly in our practice. Obviously, we get referred these patients than, say, symptoms from gastritis. So if they have typical biliary symptoms, you might do that by getting a HIDA scan to look at whether they've got a functional gallbladder. That's a bit controversial. But if they've got a polyp that has relatively is small and has benign appearances, then, as I say, they're young, less than 50, you might consider doing an ultrasound at 12 months and then having the same conversation. It's in many ways the old Hackney expression, kicking the can down the road, because at 51, you've got to do the same thing. We don't know after 5 years, if they have the same ultrasound, what the long-term future of those polyps are. It's probably completely benign, but we simply don't know that evidence. So I think all you can do is talk them through it. And some people get very anxious and they say, take my gallbladder out. Yes. It's a very different topic, as you know, but the question was, would I do a cholecystectomy for all patients with gallstones? I presume you meant irrespective of whether they're symptomatic or not. So the answer to that question is no. Simply, we don't take out all gallbladders just because the stones are there. It's a complicated topic. Essentially, if they're symptomatic, that's relatively easy. If they're asymptomatic, then we're talking about incidental gallstones, and there are arguments for and against doing that depending on the patient's comorbidity. But life has become much more complicated in 2023 than it did 30 or 40 years ago, when I think many of the guidelines about incidental gallstones, which was just leave it alone, don't worry about it. I think life is much more complicated. And what I mean by that is, for instance, if you find out you have gallstones, many people do have actually subtle underlying digestive symptoms that they don't know are due to their gallstones, and with a good history, you can tease that out. Number two, I say this to patients regularly, and again, I've written an article, I give them that article, and I say to them, I'm not pushing you to do this, but I say to them, what are you going to tell your travel insurance? Are you going to tell them that you've got gallstones or not? They go, I'm not going to tell them. I said, well, they'll find out. When you get an attack, which is a risk of 2 to 4% attack of developing symptoms, they'll find out as you're flying over, I don't know, somewhere in Russia, and they'll have to divert the plane. And if you do tell them you've got gallstones, you know what they're going to do to your premium. And it's ridiculous, but they'll do it. So these are modern issues. People don't like sitting there. And I think what's changed in 40 years is laparoscopy. Now, I'm not playing down an operation of laparoscopic cholecystectomy. It is still an operation. It is still associated with risk. But compared with an open operation, it's easy. And again, many of us, in certain circumstances, consider it just a big investigation rather than a definitive procedure. Yes.
And what's the natural history of gallbladder cancer?
So gallbladder cancers relatively vary. There's a variety of them. And most gallbladder cancers present relatively late. That's the first statement to make, because they're asymptomatic at the early stages. They tend not to cause the same symptoms that gallstones do. And it's a little bit complicated pathophysiologically why they do that. But essentially, they tend to occur very late. And we see two groups, ones that are picked up incidentally, and they're the relatively early ones that we can cure. And then there's the ones that are late that really any intervention, whether it's chemotherapy or surgery, does no benefit for. And unfortunately, we see too many of those. When they present with typical biliary symptoms, they get scanned and they have an advanced malignancy. So the natural history of an early carcinoma, if it is picked up during investigation of gallstones, like you see in these slides, we would, depending on the histopathology, and again, this is a little bit off topic tonight, but it's very critical what that histopathology of that excised gallbladder is, as depending on how much it penetrates through the layers of the gallbladder and whether there are lymph glands involved. And if it's relatively superficial, this is in simplistic terms, if it's relatively superficial, a cholecystectomy will cure that patient. If it's not, then they have a high risk of local or distant recurrence, and we go in and do a radical resection of the gallbladder bed and the lymph nodes. That's in summary. Does that answer the question?
Yeah, I was just wondering if it's untreated, what's the mode of demise?
So gallbladder cancer acts locally and it tends to cause localised pain, and it can mimic acute cholecystitis, so it can present with an acute presentation with a lot of pain, a lot of high fevers, and we even attempt to then partially do a cholecystectomy, and we find out halfway through it's likely to be a cancer. And then it spreads locally within the gallbladder, and it can spread distantly as well. But it usually is a local problem first. It's not a great cancer. I mean, no cancer is great, but it's not a great cancer to have. Yeah.
For the borderline polyps, like 6 to 9 millis, would you benefit from doing an MRI to characterize the polyp, or there's no difference?
The consensus conference of the International Ultrasound Group concluded that it wasn't beneficial, but a good ultrasound was far more accurate than an MRI. I mean, MRIs are used, contrast agents, you can use it, but ultrasound is the most definitive, and that was their conclusion. I think we need to be guided by that.
How do you know where's a good ultrasound?
Good points. I don't have any shares in any radiology practice. Most ultrasounds are pretty good. The bigger players. Is that a politically correct answer? Yes.
How sensitive is CT, existing CT of the upper abdomen? Will it pick up the incidental stuff as well as an ultrasound?
No, of gallstones or gallbladder polyps.
Right.
It's a very poor delineator of gallbladder pathology, a CT scan.
Just for sensitivity.
It's real, like we know that, for instance, in gallstones, only 30% of gallstones will show up on a CT scan. So this is a constant problem for us through the emergency department. When patients can easily get a CT scan when they arrive at the emergency department with acute abdominal pain, and we can't conclude that they don't have gallstones, which is what they're likely to do on their history. They need an ultrasound. It's far more definitive. So the CT will look at the pancreas, look at the stomach, look at the esophagus, look at the nodes, looks at gross pathology in the gallbladder, but will not be sensitive for what's going on inside the gallbladder. I think that's it. Okay.
Good evening, everyone. Thanks for having me along to give you a talk on fatty liver, NAFLD, NASH. Next week it'll be different, but apparently it's now NAFLD. Essentially, it's liver tests which are abnormal in patients who don't seem to drink much alcohol and probably have some metabolic problems and aren't comfortable in a standard seat because they're a little overweight. That's the kind of scenario which I guess you guys see these patients and potentially need to refer on for further liver investigation to clarify their diagnosis and potentially try and manage their underlying metabolic issues. I thought the talk was actually just NASH and NAFLD, which is a standard nomenclature that has been used for many years. But when I looked at Wendy's email a couple of nights ago, I realised that it was MAFLD. So there is this new move towards redefining what this condition is. It's all kind of the same thing. I'll try and go through the slides which I've provided for the BPTs for their exam. So there's a little bit of physiology, which is never a bad thing on a Thursday night. NAFLD or non-alcoholic fatty liver disease really essentially means fatty liver, which is seen on ultrasound or imaging, CT or MRI scan with associated deranged liver tests. Drilling down on the history, there isn't a significant alcohol history, hence the non-alcoholic. And we often have to exclude other causes of liver steatosis and coexisting chronic liver disease, including all those listed. Medications are important, and increasing number of medications may well cause steatosis. The common ones are steroids. Autoimmune hepatitis, viral hepatitis, as you know, you may receive a copy of the blood liver screen that I'll often send back for patients that you may have referred to me, and it's a horrific number of tests. But ultimately, you don't want to miss an unusual cause of chronic liver disease. So we tend to do that liver screen as part of the workup for all liver patients coming to the liver clinic, and also in rooms, I tend to do that as well. Diseases like Wilson's disease are a little bit hard to diagnose just on blood tests. You often have to go down the pathway of urinary collections as well, whilst cardiac failure is a bit more of a cardiac examination and echo result. It's a spectrum, really, the NAFLD group. It can vary from just straight old fatty liver all the way to something which is a bit more inflammatory and damaging, called NASH, or non-alcoholic steatohepatitis. Traditionally, we needed a liver biopsy to differentiate the two conditions. However, the histologists might mention words such as steatosis or hepatocyte ballooning for fatty liver. But for NASH, they move into a more of a lobular inflammation, which usually correlates with elevated liver tests, including ALT, AST, and GGT. Some of these NASH patients also have early fibrosis, and there are a group of patients who have never had symptoms and rarely had blood tests, but they're diagnosed with established cirrhosis with no real inflammatory process, and it's only really a history of a metabolic problem in the past or obesity that indicates that their diagnosis is probably NASH cirrhosis rather than cryptogenic cirrhosis. Non-invasive assessments of liver fibrosis, including the NAFLD fibrosis score and FIB4 index, are used and can be predictive of fibrosis and risk of HCC. These days, ultrasound with FibroScan to the shear wave elastography of FibroScan is probably the best test to look for fibrosis associated with fatty liver, and higher fibrosis scores may prompt a biopsy to exclude another cause of liver disease that isn't borne out in some of the liver screening blood tests. I tend to ask for a FibroScan every 3 odd years for patients with fatty liver. The concept of MAPL was thought up at a consensus meeting a couple of years ago by a bunch of hepatologists, including Jacob George at Westmead Hospital. This was to try and remove the concept of a condition being non-alcoholic or non-something, so patients would be a little bit clearer about what it means. Essentially, it's the combination of steatosis plus one of the following, including an elevated BMI in the overweight or obese range, type 2 diabetes, or in the absence of those two, some form of metabolic dysregulation with increased waist circumference, hypertension, dyslipidemia, insulin resistance, pre-diabetes, and a high sensitivity plasma CRP. It's a very common problem, as you know, particularly the primary health setting, with weight issues and obesity ever increasing in frequency, particularly in the paediatric population. I think the plan will be from the world of hepatology to try and make it more of a convention that this is a metabolic disease rather than non-alcoholic. The negative issues are that there are some patients who've got fatty liver disease with no metabolically abnormal indices. So that group of patients may not actually have a clear diagnosis in the brave new world of MAPL. This slide really just looks at the spectrum of disease from fatty liver through to cirrhosis with NASH in between. Looking at the top section, the keys with fatty liver are not surprising: genetics, calorie excess, sedentary lifestyle, obesity, and dyslipidemia with insulin resistance. That then translates into more of an inflammatory process with cytokine activation, apoptosis, oxidative stress, which then causes a worsening of insulin resistance, which is NASH, thereby transforming silently in most patients to more of a cirrhosis with activation of all the fibrogenic pathways. That also then causes neoplastic transformation as well. Therapy is guided towards each of those groups. I'll touch on tonight. I think we can probably get the most out of this talk with how to approach diet and exercise, to be honest. I think it's great to have a non-pharmacological approach to these patients, but it's almost like becoming their life coach to try and work out ways of behaviour modification to try and facilitate weight loss. The NASH group of patients have been heavily studied with various insulin sensitizers such as metformin, the pioglitazone, PPAR alpha agonists, the new group of drugs which you just can't get hold of unless you're on Instagram, like Ozempic, the GLP-1 receptor inhibitors, agonists, and as well as DPP-4 inhibitors. FXR activators, OB2 colic acid, and then the cirrhosis group of patients, some of the newer drugs I'll touch on, but they're more for study purposes. Treatment principles of this huge group of patients who you call fatty liver or NAFLD or now MAFLD really are targeting the underlying metabolic risk factors, which is, you know, the bread and butter for your practice in your world. Prevention of cirrhosis through identification of those patients who look like they're going to be on an advanced fibrosis pathway, and then also reducing their cardiovascular and neoplastic sequelae risks. The American Association for the Study of Liver Disease released guidelines regarding NAFLDs and lifestyle interventions and really emphasise the importance of weight loss to improve fatty liver steatosis and NASH, with just modest amounts of weight loss as well as exercise. The principle, I guess, of weight loss is really just identifying people's behaviour, modifying and monitoring their food intake, modifying physical activity and perhaps controlling the cues and stimuli in their environment. I think goal setting is something that is easy to talk about over a short consultation, but really giving them modest goals with perhaps 5% weight reduction in 6 months, reducing calorie intake, understanding what the calories in food that they're eating is, using food diaries, and the smartphone apps these days are great to try and food plan, meal plan, as well as count calories. Portion control, I think, is really, really important. Suggesting to patients that they don't necessarily need to complete a meal and feel full is something that's, I think, really simple and easy, and makes probably a big difference in terms of retraining their satiety. Fast food and being in situations where fast food is the option, they're all things that kind of are difficult to talk about, but make a huge difference in non-pharmacological. Weight Watchers, Jenny Craig, obviously limited a little bit by cost, but easy to prepare meals with low-calorie foods which have specific calories are great for patients to create these meal plans. Their eating style, you know, the onset of streaming services and obesity is just going to take off in an exponential fashion, reducing the association of food and to television or entertainment, family dinners around the table. Simple things like that, I think, will probably make a big difference to eating behaviours. Processed sugar, confectionery, snacking, that kind of thing, either at work or at home, also important. Alcohol reduction is a separate topic, but elimination of high sugar beverages, obviously, sugar taxes in the UK, and potentially looking at sugar as a something to modify the environment in shopping centres, etc., is probably going to be important, particularly in the paediatric children population. Enhancing social support, enrolling a spouse or family member in that dietary behaviour and modification of exercise is also important. Low-carb diets have been variable efficacy in studies, certainly reducing food high in trans fats, which are basically liquid oils turning into solid fats, with all those listed foods as an issue. A higher intake of nuts, fruit and vegetable, and omega-3 fish, vegetables, legumes and yogurts are preferred. It is, because it's not going to transfer the weight gain. Intermittent fasting is obviously with the Michael Mosley data and all of the books in the available online is a hugely hot topic. I tend to use it knowing that it's not something that's always sustainable, but it's almost a proof of concept for the patients. They've got a set of liver tests which are making them nervous. You guys have seen their liver tests going up over time. It may or may not be consistent with the elevated weight in the COVID period, but what it can do is give you a set algorithm to suggest to them that if they do increase their fasting period, perhaps 1 or 2 days a week, generally say Mondays and Wednesdays, where they'll skip lunch and have an early dinner, try and avoid exercise on the days they're fasting, and then bring them back with repeat liver tests in 6 months. It's rarely a patient doesn't come back with improved GDT and particularly ALT. And I think that's incredibly powerful to show that something that they've done themselves without a script and with a certain sense of now mindfulness about their behaviour and then what happens to their physiology, I think is pretty powerful. It also helps to, I guess, then plan weight maintenance by increasing their activity, because they may or may not have lost a bit of weight.
Just ask you,
Yeah.
why in particular are you not saying skip breakfast? Most people are happy to skip breakfast and have something at 12 o'clock and just drink lots of fluids until then.
Yeah, I think there's some evidence that, you're then including a sleep period as part of your fasting time, whereas if you skip lunch, you're awake during that whole period, so metabolically more active, your brain's requiring more energy, whereas if you have the fasting period to include somnolescence when you're asleep, the argument is you're not getting the most out of the fasting period. That's just one approach. I warn them that they don't feel good, but it's almost a test of principle that they've never actually skipped a meal. And you know what? It's not the end of the world, but they will survive. This slide just looks at coffee, and caffeine has been shown to be quite beneficial in fatty liver and reducing liver fibrosis across the board. As an antioxidant, this is something that improves metabolic processes, it's anti-inflammatory and potentially anti-fibrotic. Lots of studies have shown improvement in liver parameters with coffee and caffeine. Antioxidants have been studied for NASH. One of the commonest was vitamin E, studied significantly with multiple studies suggesting that compared to placebo and some of the other insulin sensitizers, there was an improvement in histology, action via oxidation of cell components. It's inexpensive and well tolerated. The Pippin's trial was a New England article from 2010 which looked at vitamin E versus pioglitazone, which is one of the PPAR gamma agonists, and placebo for 96 weeks. They showed a reduction in hepatic inflammation with vitamin E, but not with the other two, with reductions in ALT, steatosis, and inflammation. However, there wasn't a significant improvement in fibrosis in that study. The safety profile through all the studies have shown slight increase in indication that all-cause mortality is slightly higher with vitamin E, slightly elevated risk of prostate cancer in one RCT, and hemorrhagic stroke in groups of patients who are on slightly higher dose of vitamin E as well. So that was the only cloud that came over the vitamin E data. Insulin sensitizers, we'll start with metformin. There's clearly a crossover between diabetes, pre-diabetes, and NAFLD, non-alcoholic fatty liver disease, or MAFLD. In this particular study in 2011, 100% of the patients showed increased postprandial insulin in a group of patients with MAFLD. The actions of metformin has been around a long time, AMP and pathways independent and with reduction in glucose levels, improvement in metabolism, weight reduction, and overall metabolic improvement. But again, liver histology wasn't improved. There was just improvement in insulin resistance and weight loss. There have been some studies maybe showing even reduction in HCC in patients with NAFLD on metformin. This study was from a few years ago, again in New England. It showed significant improvements with risk reduction of diabetes in patients with insulin resistance with lifestyle and metformin versus placebo. The thiazolidinones or the gamma agonists essentially improve insulin sensitization. This is roflumilast and pioglitazone. There's several groups in the family, alpha, gamma, and beta. But the two drugs that we've been exposed to, the pioglitazone and roflumilast, perhaps reduce inflammation and fibrosis, but there is this side effect profile which perhaps leads to weight gain and possibly a signal about fracture risk and bladder cancer. They've been well studied, and meta-analyses suggest again improvement in steatosis, inflammation, and ballooning on histology, but again fibrosis, there wasn't a statistical improvement. The GLP-1 analogues, the glucagon-like peptide 1 and GIP and DPP-4 inhibitors, all are related to the GLP-1 physiological pathway, which has multiple sites of action around the body, intestine, liver, kidney, pancreas, importantly, brain and heart. GLP-1 analogues generally amplify insulin secretion and decrease hepatic glycogenesis. Some of the common drug names, Biotetralicity, Ozempic, Saxenda, you guys are well aware of these. And then the DPP-4 inhibitors, they inhibit the breakdown of GLP-1, thereby increasing levels, including Januvia, which is sitagliptin. This table just summarises some of the studies in NAFLD patients employing those particular drugs, and they're all quite small studies, to be honest, but the second last one there, 15 patients with MASH treated with semaglutide to the 12 months showed improved biochemistry and histology. The randomized meta-analysis at the bottom also showed decreased biochemistry across about 6 studies. So certainly some evidence that these drugs are going to be beneficial. Again, the jury's out, I guess, across the board with liver fibrosis. This is a New England article from 2021 looking at Ozempic, semaglutide in MASH. Again, the diagram to look at what the effects of GLP-1 are on the pancreas. It tends to increase beta cell insulin secretion and biosynthesis, and decreases apoptosis, and decreases alpha cell or glucagon secretion. Again, working on multiple areas. This is just a table. These slides are available, I think, in your notes, so I won't go through it. But I guess I wanted to point out that dose adjustment is necessary for these agents with renal impairment or severe liver dysfunction, and some of the side effects that need to be looked out for, including hypoglycemia if you're using it in conjunction with other insulin-type drugs, dehydration, acute pancreatitis, we've seen that a few times, and then severe gastroparesis because it tends to reduce gastric emptying. Back to the MASH study. So these were agents treated with Ozempic versus placebo. They were all overweight, with or without diabetes, with MASH and high NAFLD scores, as well as fibrosis. So, real-world patients with advanced disease. They weren't drinking and they weren't on vitamin E or pioglitazone. They all received diet and exercise counselling, and they underwent biopsies at screening in week 72. The primary endpoint was resolution of MASH, and secondary endpoints were improvement in fibrosis stage. Second paragraph suggests the conclusion was the incidence of MASH resolution is significantly higher with Ozempic and semaglutide than placebo, but between group difference in the incidence of improvement in fibrosis was not significant in the 3 different dosage groups. You can have a look at the baseline characteristics later. It's just included for your interest. Just briefly, statistically significant improvement in the resolution of MASH on that graph on the left, but fibrosis score was not affected significantly. Biochemistry improves with Ozempic, and although the fibrosis score didn't improve, the liver stiffness by fibroscan did improve, which potentially might indicate that there may be a component of a sampling error with the liver biopsy, and if the drug is continued for a longer period of time, we may see improvements in histology. These are some of the side effect profiles of these drugs, which you can look at later. You've seen that before, just the final sentence was discontinuation of treatment due to adverse events was 7% for the Ozempic group. These are fairly old guidelines from the AASLD about management in NASH, and I've got to say we may not use on a regular basis. The vitamin E advice was to give 800 units as first-line treatment for non-diabetic biopsy-proven NASH, mainly because we don't tend to biopsy these patients anymore with FibroScan. The safety issue with 800 units is also a question, so potentially a lower dose might be a better option for patients to start on vitamin E. Metformin is really advised for NASH because of the lack of evidence for improvement in histology. Pioglitazone is potentially useful, however, there are issues with safety, and most of the data was in non-diabetics. Statins are useful for dyslipidemia in patients with NAFL, but there's insufficient evidence for treatment of NASH without dyslipidemia. There's deoxycholic acid and omega-3 fatty acids, no benefit in terms of histology. Future developments include these few drugs, obeticholic acid, which potentially increases insulin sensitivity and reduces markers of liver inflammation and fibrosis. The new glutazones might be targeting steatosis and again blocking fibrosis in animal models. And the LOXL2 cross-linking collagen antifibrotics might also be something that will become available down the track. And really, in summary, I really think the primary management of these patients is at home. They are going to be often diabetic with dyslipidemia and hypertension, and they may be already on the drugs that I've been talking about for NASH. However, it's the idea of potentially empowering patients to really work hard at their diet and exercise. We're not looking for F45 style of exercise. It's more of a consistent, short, moderate amounts of exercise regularly, which will improve potentially insulin resistance, their blood pressure and sugar control. Antioxidants, potentially lower doses, maybe 400 international units might be useful. Metformin, most patients are already on that for pre-diabetes, which I think is a great option for NASH. The statins also, HCC is a risk for patients who have progressive fibrosis, hence the reason to potentially do an ultrasound with FibroScan. If you suspect patients have got fatty liver, then several of the radiology units now will offer a FibroScan service as well. There's something called CAP score, which Macquarie Medical Imaging do, which helps assess hepatic steatosis, which has been validated. So that would be one potential change from a primary health perspective, is to ask for ultrasound plus FibroScan. Smoking cessation, sleep apnea investigation and management, and ongoing cancer surveillance. The nomenclature change to MAFLD obviously is going to confuse everyone over the next few years, but hopefully it will standardise the approach to future investigations and research. Thanks very much. Yes.
What comfort can you take from a patient who is quite obese and diabetes, perhaps up to 100, and they get an ultrasound scan of their liver instead?
Yeah, look, I think that ultrasounds, just like the gallbladder question, are all relative. You know? The appearance of the liver varies depending on the distance that ultrasound wave passes to the liver. I think a FibroScan is probably the most useful for that particular type of patient. And if it quacks and moves, it's probably going to be fatty liver steatohepatitis causing the deranged liver test, even though the ultrasound's okay. You probably don't need the liver biopsy, so you go down the pathway of all those things I mentioned. and you're going to have manageable obese patients who have the ability to exercise, and those who've got secondary issues like arthritis, back pain, and poor mobility who are not going to be able to exercise. That's the group of patients who I think we are most concerned about, who are going to progress into advanced fibrosis and the pre-cirrhosis. They're the ones who will probably end up on liver transplant lists in the next 20 years. The Hep Cs are disappearing as you guys are treating Hep C, and that's going to be the problem. And I guess early recognition and trying to push the low-calorie approach to dieting and the fasting, I think, is hopefully the way to go as these new NASH drugs come on board.
In a thin patient got visceral fat, how do we would this non-alcoholic fatty liver? Is that appropriate?
Is it visceral fat clinically or with ultrasound or CT just being on imaging? Yeah. And their liver tests are normal or their liver tests are normal?
Normal or abnormal?
Yeah. So if your liver tests are normal, it's kind of reassuring because they haven't perhaps gone into that NASH phase where there's inflammatory response. They probably do have insulin resistance. So they're the ones that you want to pick out whether or not they've got impaired glucose tolerance. You would be pushing for them to start exercising, just because particularly as you saw the waist circumference is less for Asian patients, you would want them to just get onto a healthy program to perhaps avoid the medications down the track. And really the idea of potentially portion size control, skipping meals, and proving to them based on their documentation of their weight reduction is really powerful. And I think you can measure it simply with a tape measure around their circumference. That's the best indication that they've got visceral fat. Later on down the track, you can do an ultrasound or CT if you need. But the ones who've got normal liver tests, perhaps they don't have significant inflammation in their liver. This is all guesswork, you can always do a liver biopsy, but usually the ones who've got an ALT, a GGT and a high ferritin have probably got NASH.
Is the FibroScan bulk build available?
The FibroScan and Macquarie Medical Imaging is because when COVID happened, all of the FibroScans from the liver clinic went to MMI. Now, I'm not sure if an authority, I guess you can request it. It is rebatable. I just can't remember what the rebate is. Yeah.
So I can get a bulk build.
You should be able to, yeah. I think at MMI they do.
Right.
Yep.
If you have an obese patient who loses nutrition alcohol but has fairly normal liver function other than a gamma or GT,
Yeah.
and if the ultrasound does show fatty liver,
Yeah.
when do you progress, or do you repeat the ultrasound over the years, or do you progress to fatty liver?
Yeah, I think a baseline FibroScan is a good idea. Probably start with an ultrasound, get their liver tests, look for any other obvious causes of liver disease, high ferritin, high transferrin saturation, suggesting they've got hemochromatosis, the viral hepatitis. An ANA and an immunoglobulin G will probably pick out most of the autoimmune hepatitis in the group who are more at risk of autoimmune hepatitis. And then it's a path of, if someone's a little overweight, you just get them on that initial, the one on the left-hand side, diet and exercise, with a blood test in 6 months, and then maybe a FibroScan at 12 months, because they're the ones who you want to try and work out could they benefit from more pharmacological therapy for their NASH, as discussed on the slides tonight, because they're the ones that will accelerate onto cirrhosis, and often they don't have any symptoms. And the ones that turn up and, have already got low platelets, they've got a nodular liver, the horse is bolted in those patients. So an ultrasound in an overweight patient will potentially be quite useful, but I wouldn't suggest a FibroScan unless they've got significantly deranged LFTs.
Same question again, the natural history. I've got hundreds of patients with fatty liver at some level or another, and I'm not seeing any kind of storm of cirrhosis and liver failure later in their lives.
Yeah. Yeah, I think fatty liver is very common. The sequence going to NASH is the group that will probably have the highest risk to go to liver cancer, maybe 5 to 10%. But fatty liver is so common. The question is, are they going to develop NASH based on their GGT and ALT rising? You guys do yearly blood tests at the least. That should be enough to work out whether or not they're showing worsening biochemistry. I don't think you'll miss the boat if you keep an eye on their liver tests. You'll see that combination of GGT and ALT all the time. And that's very, very reflective of steatohepatitis or fatty liver. But those other indices like a slightly falling platelet count or an ultrasound that suddenly shows a slightly nodular liver. We've had a few cases of people being really frightened by a diagnosis of cirrhosis, but you just send them to another radiologist and suddenly their nodularity disappears and they've got a normal liver. So again, it depends on who's looking at the scan. I think the liver tests are the most powerful way to work out whether or not they're going to have a kind of a NASH phenotype rather than just fatty liver. I don't necessarily think you'll need to ultrasound everyone with slight fatty liver. It's just get an idea that, yes, on an ultrasound, they did have fatty liver as the cause of their liver test, and then institute the primary health stuff at that early point. Yeah.
For my fatty liver patient, I usually with the range I usually stratify them with the NAFL score.
Yeah.
If they're low risk, is that okay not to do a thyroid scan, or is that still not a good indicator? No,
I think that's a really great approach. Yeah. Are they usually patients who have a bit of a metabolic phenotype?
Overweight.
So I mean, the answer is always going to be get them to do those things, and their fibre scans or
I don't want to overorder the fibre.
No, you don't. And I think 6 to 12 months is a perfect period of time to try with lifestyle modifications, because if their liver tests get worse, then they might have an alternative liver disease. And that's the point to then potentially refer for further liver imaging. If it's a cholestatic picture, they've got thyroid disease, they've had some ulcerative colitis or some diarrhea, maybe they've got PSC. You don't want to sit on those. But, that first, they've got funny liver tests, maybe do an ultrasound to start with, just in case they've got something completely unrelated, like metastases, and then start them on the advice with goal-directed therapy, and then 6 months bring them back in for the repeat blood test. And if they've improved and you can see a reduction in their metabolic indices, then that's probably the diagnosis. And that fibro score will probably decrease as well.
So with the higher risk patient, like the established fibrosis, when do we start HCC monitoring? Is that only for cirrhosis?
Usually HCC monitoring is for established cirrhosis patients, but you never know when your NASH with F2, F3 fibrosis is going to turn cirrhotic. So I personally would do a fibro scan to get that F2, F3 number repeated probably within 12 months. And then if they're progressing, then they're on 6-monthly HCC surveillance if they get F4 fibrosis, which is basically cirrhosis.
Ultrasound AFP every 6 months?
Yeah, ultrasound every 6 months if they're established cirrhosis. That's just standard for anyone with cirrhosis.
I see a number of Asian women, lean women,
yes,
middle-aged, NASH.
Yeah.
How do you explain that?
That's this, non-alcoholic fatty liver disease. Now they don't even have a label if we're going down the NAFL pathway. They don't have diabetes, they're not overweight. I can't explain it based on the simple metabolic stuff, but generally it's adipose deposition and starts causing low-level inflammation. So whatever the small amount of fat that isn't associated with visceral fat still causes that inflammatory pathway, and that is a form of steatohepatitis. And in those patients, they're the ones that I try and push the exercise because that's the easiest way to get that those fat cells out of the liver. And portion control, even physiologically, lean patients will benefit from that idea that they're mobilizing their ketone bodies. It doesn't hurt. And it's powerful when they see their tests are better. It gives them something to do.
Right.
Yeah. I reckon.
Thank you.
As we get going. Thanks, Wendy, for arranging this evening. And thanks to DHM for supplying dinner. I just wanted to talk to you about liver cancer and actually its relevance in our community. My name's Kai Brown, and I'm a transplant-trained hepatobiliary, pancreatic, and general surgeon. And I've got a special interest in minimally invasive, that is laparoscopic and robotic hepatobiliary surgery, which is really only offered in a few centres around Australia. I've also got a strong research and teaching background, and I'm a senior lecturer at the University of Sydney, and I operate obviously here at North Shore Private and Royal North Shore Public Hospitals. I wanted just to make a few, just a handful of key points. I know it's late, but really to highlight what some surprising statistics that are really relevant for the patients that you are seeing in your rooms. So firstly, what is it that I'm really referring to when I say liver cancer? Well, what that really means is primary liver cancer, and that's predominantly hepatocellular carcinoma and intrahepatic cholangiocarcinoma. So hepatocellular carcinoma are cancers derived from the hepatocytes themselves, usually in the setting of chronic liver disease, and comprise about 2/3 or so of primary liver cancers. And then there are cholangiocarcinomas. So these are cancers derived from the bile ducts, the intrahepatic bile ducts. And these comprise about just over 1/4 of all cases. And they're genetically quite different from Klatskin or highlight tumours, gallbladder cancers, and biliary tumours of the distal bile duct. And of course, there are secondary or metastatic liver cancer, and that's a completely different entity that I'm not talking about today. So really for the purposes of this talk, when I say liver cancer, I'm talking about hepatocellular carcinoma and cholangiocarcinoma. Now, in terms of, the survival, the outlook for these two pathologies, firstly for HCC, it goes really hand in hand with the patient's underlying chronic liver disease, because these are two disease processes that go together. So the long-term survival for these patients, in somebody who has preserved liver function and a favourable tumour can, reach upwards of, 80% or so. And they can, even in patients with advanced HCC, in very selected cases, some of those patients can expect long-term survival as well. But, it really depends on proper patient selection. And I'll come back to that point later in the talk. In order to do proper patient selection, you need the expertise of a multidisciplinary team that, has the knowledge to identify those patients. And then there's cholangiocarcinoma, which unfortunately it doesn't have as good survival as HCC. Even after surgical resection, the 5-year overall survival in these patients range between 10 and 40%. But then again, there is a subgroup of patients, with a technically excellent operation, get all the cancer out, and a favourable biology. They don't have any positive lymph nodes. That they can expect a much more favourable 5-year survival. So how relevant are these two pathologies to our community? They're pretty rare cancers, and as we've said many times this evening, HCC is associated with chronic liver disease. How relevant is it really to our community in northern Sydney? And the answer to that is that it's extremely relevant. Liver cancer is the most rapidly increasing cause of cancer and cancer-related death in Australia. It's the 17th most common cancer and eighth most common cause of cancer death in New South Wales specifically. And these data really, this is federal data published by Australian Institute of Health and Welfare, showed that since 2001, the total number of liver cancer cases have tripled. It's mostly, the rate is 3 times greater in men than women, and in most cases are in patients over 60 years. It comprises about 2% of all cancer diagnoses. So that's 1 in 86. Interestingly, since 2001, again, that the mortality rates, calibrated for age, have actually almost doubled. What about if we drill down just into northern Sydney? This I found incredibly surprising. Northern Sydney has the second highest number of expected cases of liver cancer in New South Wales. Here's data from the Cancer Institute New South Wales from 2016 to 2020. And you can see second from the top there after Hunter, New England. This is by a local health district, is Northern Sydney with 500 expected cases. That's more than Southwestern Sydney, more than Central Sydney, more than Southeastern Sydney. When we stratify all of New South Wales by local government area, you see number 1 is the Central Coast, followed by Canterbury Bankstown, and number 3, with 150 expected cases, is the Northern Beaches. Okay, so this is a really relevant issue for our community. When we isolate just our Northern Sydney local health district and then break that down by local government area, again, we see Northern Beaches at the top, followed by Hornsby, Kringai, Ryde, Willoughby, North Sydney, and then the remainder roughly equal. Like more broadly in Australia, this is a trend that we see increasing over time in New South Wales. This is the trend line since the 1970s, I think, when the data was started being collected. And you can see, especially in men, there's a clearly increasing rate of liver cancer. So, why is this happening? Well, let's go back to the risk factors for liver cancer. We can kind of broadly group these into 3 main categories. One being a process of chronic inflammation, and especially with cirrhosis. And, most frequently in Australia is probably related to chronic viral hepatitis. And now keep in mind that amongst viral hepatitis-related HCC, most are actually attributed to chronic hepatitis B rather than chronic hepatitis C. And amongst patients with chronic hepatitis B, they are at risk of developing HCC even in the absence of cirrhosis. So non-cirrhotic HCC is a phenomenon that we see in chronic hepatitis B patients. There are obviously toxins, alcohol, clearly. And then a big one, which, I'm very happy that Neems was able to talk to you this evening, is metabolic factors, in particular fatty liver disease, but even obesity and diabetes, independent of whether or not you have fatty liver disease or not, are independent risk factors for the development of liver cancer. And indeed, actually, almost 1/5 of the cancer burden related to overweight and obesity in Australia is due to its impact on liver cancer. In 2017, 2018, 2/3 of Australians were overweight or obese. Okay, and this is an increasing trend over time. And this data is a bit old, from 2015, but we ranked 5th in terms of the most obese amongst OECD countries. We talked a little bit already about the mechanism of this process, but there's a very big denominator. There are many patients with fatty liver, and sure, only a small proportion of them are going to progress. But if you've got a lot of patients to begin with, it's still a large number of total cases. And it's estimated that maybe 5% of patients with fatty liver might go on to develop inflammation hepatitis. And maybe of those, maybe 20 to 40% might develop some fibrosis, which is scored between 1 and 4, up to then cirrhosis. And once you have established cirrhosis, you've got a 12% risk of developing hepatocellular carcinoma over the next 3 years. And obviously, it's much less if you've got fibrosis without cirrhosis, but it's not 0, okay? You don't have to have end-stage liver disease to be getting liver cancer from fatty liver disease. What else might be contributing in our community to this increase in liver cancer? This was another really interesting statistic that I thought I'd present to you. This is Australian data published from the Australian New Zealand Journal of Public Health. 40% of people living with chronic hepatitis B remain undiagnosed. Okay, and even amongst those that do have it, 80% are not receiving regular care. Why is this relevant? Well, this is data actually from Victoria. I couldn't find equivalent data from New South Wales, but I suspect it's very similar. But it shows that there's a clear association between your country of birth and your risk of developing liver cancer. Particularly amongst males, if you were born in Southeast Asia or Northeast Asia, you have a much greater risk of developing liver cancer versus if you were born in Australia or Europe. And that's probably because hepatitis B is endemic in those regions. And of course, all of these factors have a synergistic hazardous effect on the liver and the risk of liver cancer. So I guess from your perspective, you know, who should undergo screening? Who should you be concerned about? And, you know, if you see a patient with some of these tests coming back abnormal, what do you order next? So, you know, obviously most cases of HCC occur in the setting of chronic liver disease and cirrhosis, and there are clear guidelines for that. You know, cirrhotic patients and non-cirrhotic patients with chronic hepatitis B are recommended to have 6 monthly ultrasounds plus or minus the AFP tumour marker blood test. Amongst patients with fatty liver disease without cirrhosis, at the moment, the relative incidence doesn't quite meet that threshold for justifying routine surveillance. Now, having said that, many patients that we see in our MDT were not previously known to have risk factors. They may have risk factors at the time of their presentation, or maybe they have no recognisable risk factors at that time. And the vast majority of them are asymptomatic. That's especially so with intrahepatic cholangiocarcinoma. So really, what I hope, to you as the primary healthcare providers have, in terms of trying to pick these things up early, or patients who are up at risk early, to give them the best chance of, surgery and cure. And I would say, be alert, not alarmed, but be alert to persistent and unexplained LFT derangement. Obviously, this is a massive group of patients. Only a minority of whom are going to be harbouring something, sinister and malignant there. But often in retrospect, when we see these patients, the only kind of clue you might have seen is maybe some deranged LFTs. So if you're doing a blood test on a patient of yours, and they do have some, routine blood tests and got some abnormal liver function tests, think about it. Is this a hepatocellular pattern? Is it a obstructive pattern, or is it a mixed pattern? In fatty liver disease, usually it's going to be a hepatitic type cause. It's going to be a hepatocellular pattern, the ALT and AST. Or if you've got, a lump in the liver and there's some upstream biliary dilatation, often it's a mixed type pattern with some alkaline and GGT elevation. And then, like most things, the next step, you've got to take a really good history and do an examination. In particular in the history, you're going to be trying to identify risk factors or causes of chronic liver disease and exclude other causes, benign causes of LFT derangement. And there are many which we've already talked about this evening. If there are no red flags, or maybe there are a few risk factors there, they've travelled internationally or they've emigrated to Australia, it might justify doing a liver screen at that time. But otherwise, it's very reasonable just to repeat their blood tests in a couple of months' time. Maybe they've had a viral illness. But if the blood tests are still elevated, I think that's rather than to say, there are many patients like this. I think if they're persistently elevated, you should escalate that. And then the next most appropriate test I would put forward to you is, in addition to a liver screen, is to do some imaging with an ultrasound. And indeed, most diagnoses, when in that small percentage of patients that do have something malignant going on, most diagnoses can actually be made on imaging alone. So we've already talked about ultrasound, but say, for instance, you do the ultrasound and there is a lump there, or there's some biliary comment about biliary dilatation. What can you order next? It's reasonable at that point to refer the patient, but what can you order next? And I think the next most appropriate test is to do a CT scan, and specifically what we call a liver protocol CT scan. Okay, that's a 3 or 4 phase CT scans, 3 or 4 CT scans taken at the same time with at different points when the contrast agent is circulating around the body. And in these 3 panels, in the first one, I can just bring up the pointer. You can see up here, there's a little lesion that sort of stands out relative to the rest of the liver. And here it's a little bit less dense. And then on the delayed phase, it's even more so less dense related to the rest of the liver. And what this actually gives us way more information than if you write on the form CT abdomen, right? If you do CT abdomen, they'll probably do a single phase portal venous contrast, and often we've got to repeat that scan. Okay, so if you've got a lump in the liver, the test to order is a liver protocol CT scan, and that will give you most of the answers most of the time. Occasionally, the radiology practice might recommend doing an MRI scan, and that's also a very useful test, but they can only be rebated by a specialist, and there are specific indications for that. One of which is, the possibility of a HCC. So if there's an indication to order an MRI scan, it's probably an indication to make a referral as well. Tom's already touched on this about radiology, where you get your radiology, but not all radiology practices were created equal. And indeed, not all radiologists are experts at hepatobiliary pathology, nor is it reasonable to expect them to be. Their community radiologists are looking at dozens of scans every day of all types, of all parts of the body. All I do all day is look at scans of the liver and the pancreas. And indeed, so do the radiologists in our MDT. So what I would say to my patients and say to you is, if this is going to make a difference, don't go to a reputable provider, maybe a provider that's associated with a hospital that, does this kind of work, because it really makes a big difference. So when should you refer, and what can you tell your patient is going to likely happen next after you make that referral? So this is actually very straightforward, and I think, you should refer to a hepatologist or gastroenterologist. Certainly all patients with, at least, all patients with F2 fibrosis on a fibro scan. Definitely all patients with a new diagnosis of cirrhosis, and obviously all patients with evidence of chronic liver disease. They might be portal hypertension, might have societies, they have some synthetic dysfunction in their blood tests, or, they're maybe having episodes of encephalopathy. This might sound obvious, but I think anybody with a lump in their liver, a radiological mass, or any biliary dilatation should be referred to see a hepatobiliary surgeon. So not a general surgeon, not a surgeon that has any interest in gallbladders or sometimes livers, but a specialist hepatobiliary surgeon. Sometimes these patients get referred to the gastroenterology clinic, and then they may bounce then to the surgical side as well, which might, delay somewhat their workup. So anyone with a lump in the liver or biliary dilatation should see a hepatobiliary surgeon. And where you refer the patient really matters. I'll present some evidence to support that. In one part, because the treatment of these patients are really complex. You're often treating their underlying chronic liver disease and their cancer concurrently. And that sort of treatment requires, an MDT, multidisciplinary team, that can really only be provided at a tertiary level hospital. And I think that's one of the benefits that we have here at the North Shore Private North Shore campus, is that our MDT for the private and public patients is the same. Okay, so that benefits obviously the patients in the community, but it also benefits the patients, benefits the MDT in terms of increasing the case volume. This little 3D reconstruction here that I'm demonstrating to you, I actually did this on my laptop. It was a case that I did a couple of years ago. He was in his late 20s, and he had a rare subtype of HCC that occurs in young people in the absence of chronic liver disease. And he'd actually been knocked back by 2 other major hospitals at the time, and had eventually made his way to our MDT. obviously it's a big cancer. He said it's wrapped around all those blood vessels. But we were able to offer him an operation because there's no other systemic options for this particular type of tumour. And it involved, you know, cooling the liver and resecting the inferior vena cava and replacing that. But it gave him the best shot at you know, maybe having some reasonable survival. But there's nowhere else in northern Sydney that can offer that service, okay, that kind of depth of the NDT. And this is borne out in the literature as well, the centralisation of these sort of specialist services. There's good evidence to show that the survival of these patients is proportional to the hospital volume. Okay, it's not just about the technician, the surgeon doing an operation. In fact, many of these patients won't need or be able to have an operation, but it's about the decision-making process and the comprehensive care that they receive. One person who I haven't, I by mistake left off this list is actually our liver cancer care coordinator, Ellie. So any of our patients that come through that need a major liver resection, you know, they get her number. That's a point of contact. She expedites their appointments, scans, etc. So they're guided through the whole process. Now, in terms of treatment options, there are many. I'm not going to go into a lot of depth about these, but essentially, you know, there are two groups. There are, you know, destructive kind of treatments that with curative intent that includes surgery and liver transplant, as well, you know, to some degree ablation. And then there are non-destructive without curative intent treatments that includes chemoembolization, where we block off the blood supply to the tumour, and radiation, either internal radiation or external beam radiotherapy. But ultimately, surgery is the only curative option. And again, surgical and cancer outcomes are proportional to both the hospital and surgeon volume. This is especially true for minimally invasive, that is laparoscopic and robotic liver surgery. And indeed, there's separate evidence that shows minimally invasive surgery for HCC is associated with better survival and surgical outcomes. It's especially true in patients with cirrhosis. So now, myself as a you know, a minimally invasive surgeon, I can't help but to show you at least a couple of photos and a short video of some surgery, but I'll keep it brief and really just to highlight, you know, some of the more advanced techniques that we can offer. So in these two photos is what we call ICG tumor staining. ICG is a fluorescent dye, so we inject it intravenously into the patient, and it's taken up by hepatocytes, and it's exclusively excreted by the bile ducts. Now, hepatocellular carcinomas, they don't have bile ducts. They're a neoplastic proliferation of hepatocytes. So they take up the dye, but they can't excrete it, and therefore we can stain the tumours. Okay, so, and then when we're doing laparoscopic on the left or robotic surgery, we can turn on a fluorescent light, which sees the glow from the dye, and the glow has about an 8 millimeter penetrance through normal tissue. So it gives us a safe margin away from the tumour. And so this is a technique that, you know, I used a lot last year, and I think is something that's exclusive really to minimally invasive surgery. This video is a robotic right hepatectomy that I did last year. So that's removing about 60% of the patient's liver. And, you know, this right here, I'm actually controlling the right hepatic artery and dividing it. And really just to illustrate the precision with which the instruments can move and the exquisite view that you get, which is far exceeds that which you can get at laparoscopic surgery. And you know, if you haven't seen the robot, this is essentially what it looks like. It's 4 arms suspended from a pylon that goes above the patient. It's kind of like keyhole surgery. But this is me controlling the robot sitting in the corner of the big grin on my face, because it's actually a lot of fun. But what's more relevant to patients and what's more relevant to you, where you send your patients, is this. Now, even a small lesion in an awkward location can for liver surgery can require a massive incision. Okay, as opposed to robotic surgery or laparoscopic surgery, we're going to have a handful of small incisions And we usually, even for say, if we take out half or more of the liver, we take it out via a fan and steel type cesarean incision, which is much better tolerated than say a laparotomy. And I can tell you personally that from, last year, my average length of stay for these sorts of patients was 4 days. Okay, so, patients have 60% of the liver removed and they're going home 4 days later. Obviously, these techniques have a trickle-down effect on other aspects of general surgery, emergency surgery. So I guess the take-home messages and key points, liver cancer is one of the few malignancies that's significantly increasing in incidence in Australia. Northern Sydney, in particular, is one of the highest incidences of liver cancer in New South Wales, and I put to you that's mainly due to fatty liver disease and chronic hepatitis B. From a primary healthcare perspective, I think, vigilance around abnormal liver function tests, particularly within, at-risk patient groups, gives them the chance for, early detection and their best shot at a good outcome. And, I highlight again that, having that centralised multidisciplinary team process that we have here on this campus and having a patient reviewed by a high volume centre is critical really to optimising their outcome. And with that, I'm happy to take any questions.
Got two, sorry.
Oh, yeah.
If someone had a liver screen done ages ago, you can see it, it's all normal. And then a few years later, the outcomes are still abnormal. Do you still do the liver screen again, knowing that it's normal before, or do you just look for other causes?
So they had some abnormal tests a few years ago.
Someone did a liver screen.
And they did a liver screen, that was all fine.
And then
You see them now a few years later, LFTs are abnormal. I mean,
screening again?
Unless they have, again, you can probably take that from the history taking, unless something about their risk profile has changed, probably you don't need to. Okay, the most likely scenario for that is that they're probably got fatty liver disease. And a lot of patients with fatty liver disease are not necessarily overweight or obese.
The second one is liver hemangiomas and focal nodular hyperplasia.
So the question was about hemangiomas and FNH. So a completely, a different pathology, but an important one because many of the features of those on CT scans overlap with hepatocellular carcinoma. And, most of the time you can diagnose one of these on that liver protocol CT scan. Usually that'll give you adequate information. And if it's a, barn door hemangioma, and the radiologist is very confident about that, those are not malignant. They might get bigger, they might get smaller, they rarely cause symptoms, and they, exquisitely rare to bleed. Okay, there's a few documented cases in the literature. So by and large, those patients don't need follow-up. Similarly with the FNH, this is a benign lesion, usually seen in focal nodular hyperplasia, benign lesion, usually seen in young women, and do have some characteristic features on that triple phase or quad phase CT scan, but occasionally it's hard to tell. Okay, and if it's not 100% clear, then the next best test is to do an MRI scan, and that can only be rebatable via a specialist referral, specialist ordering. Additionally, occasionally, something labelled as an FNH will come back to bite you. So I would say that if something's been called and come back to bite you in the sense that it's not an FNH, it's actually an adenoma, or even a cancer. So I had another case of a patient with that's not that same 3D reconstruction, but another young person with what we call a fibrolamellar HCC, and sometimes these can be mistaken for FNHs. So, I would put to you, if you have a patient with an FNH, it's always worthwhile having a specialist, even though the radiologist is called to that, having a specialist hepatobiliary surgeon look at those scans, and sometimes they might need further imaging to confirm it. If it is confirmed as an FNH on an MRI, that's very definitive. They don't need any further follow-up.
How do you tell if it's liver cirrhotic or fibrotic?
So, I mean, predominantly that's initially it's going to be via the fibroscan. Okay, so yeah, the fibroscan essentially sends a shock wave through the liver and it measures how long it takes to come back. And if the stiffer the liver is, the more fibrotic it is. So if it's super stiff, it's probably cirrhotic. Sometimes with an ultrasound or on a CT scan, you can actually see that the liver is nodular. Okay, it's clearly, just macroscopically to the naked eye, it looks cirrhotic. Or they might have other surrogate signs of cirrhosis, of portal hypertension. So you might see that on the scan. They might have some ascites. They might have some varices, or even clinically, if they have caput medusae, for example. So these are signs of portal hypertension from cirrhosis.
So as GPs, we do alpha-fetoprotein. How confident can we be that that's normal?
It's not a good, so in the setting of cirrhosis or chronic hepatitis B, where you're doing screening, they still need an ultrasound number one. The AFP is useful, but if it's normal, it's not the be all and end all. Okay, because some HCCs don't produce AFP. Yeah. Yeah.
How do you decide how much liver to take out of time for cancer and virusides?
Yeah, I mean, that's a really interesting question for me as a liver surgeon. It's partly on the geography of the location. So you can have a small thing next to a critical structure. If you've got to take that critical structure, you might have to take a lot of the liver that's supplied by that critical structure. Or you might have a large lesion that's just hanging off, like a grapefruit, and you actually don't have to remove much normal liver. So that's one thing. The second part of that question is that more and more we're moving towards parenchymal sparing surgery. So, we used to kind of do what we call anatomical resections for a lot of cases where we'd remove a large portion of liver with the idea that would reduce the likelihood of recurrence in the liver. But I think the evidence around that is, controversial, and more we're moving towards parenchymal sparing. And, that's actually in many cases can be technically more challenging in some scenarios. And, some of these minimally invasive techniques, being able to do those while still be able to preserve normal liver, that's where the skill and the planning comes in. And that's where I like to do those 3D reconstructions to help me plan the operation. The patients love looking at it, understanding what's going on inside their body. So it's a case-by-case basis, basically.
Can you say a few words about, for example, managing the liver surgery and also the follow-up?
I beg your pardon, the post-operative, yeah. So it depends on the degree of the liver resection. So if for the majority of the patients, if they have plenty of adequate liver volume remaining, they'll have a very uncomplicated post-operative recovery. Okay, particularly if we can do it minimally invasively, and they're getting back to most of their normal activities, within a reasonable time frame. Often they might feel tired. They're healed on the outside, but their liver is using a lot of energy to regenerate and hypertrophy. In patients where we're doing they've got a borderline future liver remnant, we're doing massive resections, because it's a big tumor in a critical location. The post-operative management of those patients are more complex, and not infrequently they might go home because they're surgically dischargeable. Then you might represent to their GP saying, "Oh my goodness, my abdomen's swelled up." They've suddenly retaining a lot of fluid. If that's the case, you need to get on the phone to the surgeon. They might need to do some scans, and sometimes, if you do a big liver resection, all that blood that was going through, the original volume of liver is now being shoved through a much smaller volume of liver, and they effectively get, portal hypertension, on the short term whilst their body accommodates, and sometimes they need diuretics to help manage that.
For the follow-up to cancer surgery.
I mean, the follow-up, essentially, us as cancer surgeons, we have a lifelong relationship with that patient now. We're going to be looking after them forever. Okay. So we're going to be looking after their surveillance scans, monitoring. you know, whether it be face to face or, you know, in conjunction with a GP over the phone or the patient over the phone. So, you know, usually in the first 12 months, they're going to be followed up with scans every maybe 4 months or so for the first couple of years, and then spacing it out along with blood tests, depending on what their original tumour markers would be. Yeah.
Can I add that we have a prospective liver resection database where we have about 1,200 liver resections that we've resected for the last 25 years. And we follow them up lifelong until they die, in conjunction, as Kai said, with GPs and the medical oncologists. So we keep prospective data on all our, and we produce regular papers from that.
Can you recommend a radiology practice where you refer?
I don't want to, you know, sort of name names or anything, but I think, you know, if you're referring to a radiology practice whose radiologists work in the MDT where we undergo the decision making for these cases, you know, they're the experts, because if they see something weird, they're calling us straight away, or they might say, "Can you come down and tell me what you think about this? You know, as a surgeon, you know, what do you think is going on here?" So, you know, I usually will refer most of my patients here to North Shore Radiology. They're very good. There are many other good radiology practices in Sydney, but, you know, those radiologists work with us every day. They come to our MDTs. We speak to them multiple times a week. So, you know, I can personally vouch for their expertise. All right. Well, thank you everyone for coming in this evening, and thank you for sitting out here.